figured I'd start the panel off with a question about the advantages and disadvantages of cohorts that are focused on a single pathogen or a single infection versus ones that are more ecumenical in that regard.
One of the big advantages, I think, for cohorts that really focus on a single pathogen, like focusing in on influenza, is that the more you ask your participants to do, the lower the actual follow-up is, right? And so if you're doing like 5 or 6 respiratory viruses and asking them to come in each time they get those for blood draws and for additional visits, you'll get a lot more loss to follow-up, and the compliance will be incomplete. It's just, that's kind of the way it is. So I would say that's one of the big benefits to focusing in on a single pathogen. On the other hand, like expanding out to multiple pathogens that makes sense given kind of the overall design of your study really is much more efficient, right? We should try to get as much out of these studies as we can. And so I always think it's a careful balance. So, our studies, well, except for the one in Michigan, were all initially set up to study influenza, but we've done RSV, human metapneumovirus, seasonal coronaviruses. We expanded to COVID as well. For COVID, we did put into place additional blood draws and additional things that are or can be a burden on the participants, but we really thought that was super useful. For RSV and human metapneumovirus, seasonal coronaviruses, we just took advantage of the data and the samples we were already collecting for flu.
So building on that, maybe Pia and Sue, can you talk about how easy it was to pivot to COVID in these cohorts?
Yeah. I think pivoting to COVID specifically was not too difficult, mainly because we had the setup already there. So we had, with the infrastructure, all of a sudden, and at the time, only COVID was circulating, flu was gone, RSV was gone. So the families were coming in for illness, and at the time, everybody had this heightened fear of COVID, so they wanted to come in. And so because of that, we were able to do all of that testing, which was great. I will say that now people are more weary of COVID, and so it's not as easy, and because of the availability of rapid tests, it's not as easy to have families come in. But I think the importance of this infrastructure is very important for any future pandemic, or even change in the SARS-CoV-2 variant, that's, we're able to see these patients quickly.
Yeah, I just want to add on a few points. I think I agree with the peer that COVID is really a drawing card for our cohort because we don't have a flu for 2 years, and the fear factor allow us to use COVID as a means to say, would you like to joining us for that? So that is really beneficial for that. And I think, to get the blood test is one of the disadvantage. If you including more, say pathogens like COVID and the flu both together, we actually last year, because we have both very high level, and the resource perspective is drained because of that. But also participants, don't really want to have so many runs of blood collection. So we probably have to think hard, as Nikki said before, engage with our community, our household, to find the balance. What is the moment they can accept it, or what is the moment they may feel this is too much for them. So yes, I think some of the colleagues of Tony and Nikki interested in understanding the qualitative study for our household families. I think that's probably one way for us to engage and to test the water, to design the platform in a way acceptable by the participant. Probably needs a bit of two-way communication on that. Another thing I want to add is, yes, blood collection is really the worst for participants to comply. However, the swab is not too bad in our experience, and especially COVID actually taught the participant to do self-swabbing, which is extremely beneficial for us last year. You know, we used to use nurse go to participants' home to take a swab, but now we actually just ask them to take a swab, and from the swab, you're able to draw information from not just COVID, the flu, and many RSV, very, very important pathogen, and many other respiratory viruses like human metapneumovirus, etc. So that potentially is the area we can do more, just using the available samples to answer a bit more questions for this infectious disease, viral infection area.
So pivoting from that question, maybe Dr. Webby can address what do you see as challenges in the next few years? So, you know, at least in the US, the NIH had this big expansion of funding during COVID. They funded a bunch of new cohorts. People want to keep those cohorts going, and it's starting to, you know, the funding's not there to keep everything going. And so there's going to be fewer cohorts. And so as a group, should cohorts that are left try to do more? Or what do you think the appetite is from the NIH, from our institutions and so forth?
Well, the appetite, perhaps you've got people online that can answer that better than I. But no, I think it's right. But again, I think it's going to funnel back to those that have the longitudinal data are the most valuable, right? So I think that's where, you know, the cohorts that we all got sort of presented on this afternoon have an advantage over some of the newer ones. There is just that sort of longitudinal information there. But yeah, at the same time, yeah, I think we do have to perhaps get a little more smarter about how to utilise the samples that we have collected, and, you know, particularly from the PBMC perspective, right, which is probably the rate limiting sample type in all of these studies, and that's where the technologies that you talked about are, you know, are going to come more to the fore, and learning a little bit more about how to make best use of those most limiting resources in the cohorts is going to be critical. You know, I think, in many respects, we probably have enough serum to, you know, do quite a few studies on quite a few pathogens. You know, the swab, extract a bit of RNA, we can do plenty of stuff with that, but it's really thinking about what's limiting and how to share those, and it's not it's not immediately obvious how to do that. I don't know if this might be on the screen.
Yeah. So we're in the process of talking about some of these very issues. I think that you know, we don't have a specific answer yet, but you know, I think the key is probably in the future going to be on groups that are looking at multiple pathogens, not just an individual pathogen, for some of these cohort studies, but we don't have a specific outline as of yet.
Thanks. So for any of the cohort leaders, you know, we've got this really diverse group, 3 continents, is Nicaragua 3? No, 2. North America.
North America, but it's tropical, right?
Yeah. I wonder what your experience has been, at least in the US, there's been an enormous amount of politicization now around infectious diseases as a concept almost, and certainly around vaccination. And has that affected cohort recruitment, follow-up, subject selection, anything along those lines? And I imagine it might be different in the different countries.
Speaking for the US, that there are definitely different parts of the population that want to be vaccinated or don't want to be vaccinated. And as a clinician, I very much push vaccination. However, for the cohorts, we want to look at both, right? So if they come and they want to be vaccinated, that's great. We encourage that. We will study that, post-vaccine. If they don't want to be vaccinated, we will study post-infection. And it's unfortunate that that's how it works, but many times that's how it works.
So just to follow up on that, so you have people that are eager to be in the study, but then don't want the vaccine.
That's correct. Yeah, and those are the ones that we saw with 4 episodes of COVID in 3 years, and it's pretty amazing to me that they still don't want to get vaccinated, but they don't want to get vaccinated.
In Aubree, Nicaragua, they have such a high vaccination
And they did for COVID as well. So over 90% of the population got vaccinated in, I don't know, 3 or 4 months' time when the vaccines became available. And they rolled out in age groups, and so it was super high uptake for COVID vaccination. We haven't actually seen much of an impact on enrollment into our studies throughout the pandemic. During the first peak in particular, we slowed enrollment. We were very careful about kind of interacting with people because the peak in 2020 was quite severe in Nicaragua, and we didn't want to infect anybody, right, by like having them come in to interact with the team. But kind of outside of, but we caught up really quickly as soon as the rates dropped to a more acceptable level. But yeah, we haven't seen too much impact. The one thing that we are seeing a little bit more of now, particularly with our households, which I would ask the NIH to like think about that a bit, is that we're doing flu and COVID in these households. So we activate them when we detect influenza or COVID in the household, which means we go in, we take, they're already getting blood samples taken twice a year. But now we go into the household, we collect a blood sample on everybody in the household. We try to get as many PBMCs as we can. But depending on how many houses we have we can't process more than, I think, 68 PBMC samples in a day, which is a good number, but you can have more than that. And then we collect a respiratory sample, 5 or 6 respiratory samples, regardless of symptoms, in that time period, and then a follow-up blood sample. And so what is starting to happen now is they're getting tired of it, right? So we're getting some more loss to follow-up than we've ever had before now, or people withdrawing, because they're just like, you know what? We've had 10 blood samples this year for various like activations, because we've had some houses that are activated twice for flu and 3 times for COVID in a year, and so that's something we're kind of trying to deal with and think about. So we have seen an impact with that.
Well, for New Zealand, our, as you know, our vaccination coverage rate is very high. So when we are doing our, for example, vaccine effectiveness study, our purely non-vaccinated family is much, much smaller number. And I don't think it affects us very much in New Zealand context in terms of recruiting participants, because we said our message is very clear. This is to inform future vaccine development. It's not a requirement for vaccination. So from that perspective, it hasn't been really affected very much. But I have to share what Aubree's concern, and we don't have a situation we enrolled the household dynamic sub-cohort 3 or 4 times, but even just to say, one family with flu, another family with COVID can be tough for them. Yes, so we are conscious about that part.
And the difficulty, part of the difficulty with that is, some of these questions you don't need longitudinal, really, right? Like short term. But for some of the things we really want to look at, like how people build up immunity long term, obviously you need the same people for a very long period of time, and that's where it starts to get really complicated.
So I have a few more questions, but I did want to see if anyone in the audience had a question for anyone in the group.
Thank you. Just going back to the conversation we had earlier today, if people in the COVID are curious about the results, the outcomes of the study, is there a mechanism for feeding back to them what the study found? Are they interested to know?
Yes, I think Amanda's question is about feedback the result to the participant. Yes, this is the area always our participants want to know the result. So we can provide the result for swabbing, and especially the flu and the COVID, and we're trying to give the result back to the participant as quick as possible. And for, say, other viruses like RSV or other human metapneumovirus, we would be late because the laboratory batched them laboratory do test within 24, 48 hours. Provide the result is for flu and the COVID, but the other viruses they batch them up, so we give them maybe in a week, within 1 week. We always struggle about the blood test result because our New Zealanders concept that we give you blood, you give me the result next day because it's about your glucose level, your other, normal routine kind of blood test result. So they consider this as we want to know the immunology result as well. So this communication has been a little bit hard. We have to repeat our message quite many times. And we hoping to use our epidemiological discovery, like our paper in the Nature Communications or that kind of information back to the participants through our newsletter, etc., or on our website. Yeah, but we're struggling with how to give participants with the T cell, B cell antibody result, and to explain that is enormously difficult. Even I have to scratch my head for lots of course results. Yeah.
Maybe a question back. Do you think it matters that they understand it to a certain degree, or just the fact they see, wow, this is what I'm actually contributing to? Because it's the same thing. Paul talks, and I sit there with their mouth drop open a little bit as well. So, it's a question to you guys. I don't know the answer. Is it some heads nodding?
I think they're just happy to get the result and happy to know that it's either COVID or it's the flu or it's the RSV, whatever. All the other things on the bottom. Oh, okay, well that's good. Well, I don't know what that is, but it'll be fine. Yes. Cool.
Well, sorry, I've missed quite a bit of the session, but I'm just going to check that it might be clinically or from a personal point of view quite important information to know, particularly if you've got a variant that's currently circulating as opposed to one that was circulating more dominant 2 months ago. I mean, is there a value to the individual in knowing that level of information?
Yes. So this is something, we really want to thank you and the ESI's whole genome sequence team. They are doing this especially for us. For every single COVID positive result, they are doing whole genome sequencing for us. And we want to know whether they are BA2 or BA5 or with any more fine-tuned results, more high resolution to tell more stories. So we're going to do that. And that result, actually, they just finished for the whole cohort, which is about over thousands of the samples, not about the household transmission, that's additional, I don't know, maybe 500 samples. But anyway, we are planning to give that result to our participants. We're hoping that would give them, the interest to know what is the variant.
I was just going to say, so in Nicaragua, I would say the population kind of as a whole, they care about their individual results, right? They want those returned, and for blood tests, that's always a little bit more questionable, but we put those into the medical chart so that the clinicians would have access to that. We do a lot of education of our field workers and our nurses and doctors about the study results so they can discuss them with the population, because to deliver a newsletter, we would just have to go house to every participant's home, and it's unclear how interested they would be, because we have tried that before. What they really care about, though, is more of the community perspective. So what they want to hear about is how we are feeding that information into the public health system, how we're letting the Ministry of Health know, what to make sure that it could have potential impacts for the community as a whole. So we do a ton of that, and let the community know that as well. And so, our doctors know and stuff like that, but we also have kind of billboards as people come into the health center, and we'll put up information about how that, information for them to help protect themselves from COVID, for example, things like that. But also information about how that how data from the study is being fed back into the Ministry of Health, and potential like kind of policy impacts that have been put in place.
So at our site, we offer the PCR results just like every other site, usually next day. And then we do also provide the serology results, so it gives them a reason to have the blood draw, and many times it's what draws them in because they want to know what their antibody is. This is for COVID specifically. And sometimes, though, I will say that we've run into some issues where they say, oh, it looks like my antibody's good, so I don't need to get the vaccine. So we say, no, you should still be vaccinated. You know, so there are, we do have to explain the results and what they mean, but it doesn't mean that they shouldn't be vaccinated. And then when we do have results from, you know, actually analyzed results, then that we don't often discuss the specific results, but we do, when we see the families in follow-up, we say, you know, your blood, your sample contributed to this kind of work. And we also go through our media team within our hospital system to try to put that result out there so that the community can see what they're contributing to. And I think that that's helpful.
Can I just make one quick comment? So the tests that we do in the lab, we can't return because we're not a clinical lab, we're a research lab. But it is starting to raise a lot of issues, so I hinted at it in the talk today, but just with simple sequencing reactions, especially as we learn more and more of this code of those TCRs and BCRs, we can see someone's entire immune history, again, without even looking for it. So we can see if, you know, CMV, EBV, everybody has those, that's not, you know, controversial, but we could see, you know, STDs, HIV, things like that as well. And so, one, we wouldn't want to return that necessarily because we're not a clinical lab and we're not, people don't necessarily want to send it to a study to get that information back at them. And so I think as technology gets better, there's going to be a lot of these issues of information that are going to be really critical to solve.
I just want to add one thing, you know, we are a small island country and we have a bit of island mentality. Small country participated in a very big, significant international study. So the participants buy in this quite a lot. And our midwives and the nurses would also relay this, and they are the participants are the one to feedback to us the reason why they're joining us is because of that. So to avoid, you know, all those, you know, blood sample in terms of its result, etc., we're trying to use epidemiology to tell the story, what is the difference that they are making. I think that somehow is working. And in fact, I do have to take this opportunity to thank NIH and this cohort actually fill in a gap for us in terms of our New Zealand's understanding of community transmission, because we don't have, we all know this morning we discussed about the community level, the IOI surveillance was interrupted because the patient flow is completely interrupted. To have this very systematic ways of doing sampling and doing the testing, and the testing actually is from a very high quality laboratory of our NIC. That actually gives us the result to be able to, you know, combining with the other surveillance to give people understanding at the community level, at the mild infection level, what is the virus is causing the havoc. So that is really, thank you very much for the money for that.
I just want to thank the panelists and the folks online as well. It's quite late in the US now. So.